Good evening, guys. I've got discussion C for you. We're discussing an alarming trend with nursing homes that are understaffed. Which I mean, the subject is tonight is chemical restraints. That means, for layman's terms, that means giving antipsychotics to residents to keep them quiet. Um, so there's less bell ringing, um, less distraction for people. So I'm gonna explain that to y'all tonight for discussion C. I'm also gonna give my after this show. I'm going to give my personal feeling on it. So give me a few minutes to set up for the show, and I'll be right with you. Okay, guys, here we go. The headline you're asking about is a provocation, provocative distillation of a troubling pattern emerging in the U.S. nursing homes, U.S. nursing homes, based on the article analysis. It refers to the increasing use of chemical restraints, primarily antipsychotic medications, on elderly residents due to chronic understaffing. Here's here's what the page reveals in context. Okay, first headline. What's happening? A recent study by the Pensions 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 Research Council at UPenn's Wharton School found that understaffed nursing homes are significantly more likely to use sedatives to manage residents. Facilities short on staff may turn to medications to keep residents docile. As 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 it reduces workload for folks. A controversial work around in lieu of proper care. Why it's escalating. The Biden administration proposed staffing mandates in 2024 to ensure minimum care standards, but these were defeated politically and legally. The Trump administration's legalization, not only legislation, not only blocked these mandates, but also cut Medicaid funding, which nursing homes rely heavily on. As a result, the study estimates that 24,000 additional residents could be subjected to chemical restraints annually. Profit versus care. Nursing homes operating for profit were especially likely to resort to these methods. Staffing data and sedative use from over 16,000 facilities were analyzed, showing a direct correlation between fewer nurse hours and higher antipsychotic use. Broader systematic issues. Immigration policies reducing the caregiving workforce have compounded the issue. Regulatory loopholes may allow facilities to reclassify dosing or doses, e.g., schizophrenia, to justify sedative use. Ethical implications. The article closes on a sobering reflection. While this problem is long standing, documented as far back as the 1970s, the public largely remains detached, assuming these abuses won't be uh, uh, won't affect them personally, but the aging population grows and regulations weaken. It 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 raises urgent questions about how society treats the most vulnerable. Giving your focus on frailty aware care and memory friendly interventions, this touches directly on your work. Would you like to explore solutions being proposed or how alternative care models are addressing this ethically and particularly uh, and practically the ethical implications are profound, especially when you consider how sedatives, often anti antipsychotics, can shift from being therapeutic tools to instruments of control in understaffed and overstressed environments. Here's a breakdown grounded in the article and surrounding page content. Loss of autonomy and consent. Sedative use as chemical restraints may override residents' ability to make decisions about their care. In many cases, medications are administered without informed consent, undermining ethical principles like autonomy and dignity. equity and equity and access concerns. Understaffed and low income facilities are uh, disproportionately affected, meaning vulnerable populations, especially Medicaid dependent residents, bear the brunt of these meds because they have lower income to pay for care. So they're the ones that low staff targets, folks. The systematic use of sedatives becomes a stand in for personalized care, reinforcing inadequates in access to high quality caregiving. Misdiagnosis and justification loopholes. Facilities might reclassify diagnosis, e.g., falsely labeling someone with schizophrenia uh, to justify use of antipsychotics. This raises legal and moral concerns around data falsification and manipulation for operational convenience or profit. Therapeutic integrity versus institutional effectiveness. When sedatives are used primarily to keep residents manageable, it erodes the therapeutic purpose of medication. There is a inherent conflict between institutional convenience and individual well-being, especially in for-profit facilities. Societal detachment and oversight gaps. The public perception that this won't happen to me leads to insufficient security of these practices. Weak, weak regulatory frameworks and defeated staffing mandates open the door for normalized unethical behavior. You're already tuned into frailty aware care and memory friendly design. So, this conversation goes far beyond theological ethics. It's about systematic responsibility and deeply human values. Want to explore what alternative models are doing right, or how policy could better reinforce ethical uh, protections? Great question. And right in your wheelhouse of frailty aware and memory friendly innovations from the document and broader uh, Le- literature, several care models stand out for successful reducing the reliance on sedatives through more holistic, person centered approaches. Okay. Focuses on eliminating loneliness, hope, helplessness, and boredom in nursing homes. Uses companionship, meaningful activity, and resident empowerment rather than chemical control. Studies show significant drops in uh, antipsychotic prescription where where it's implemented. Greenhouse project, small home-like environments with high staff to resident ratios and flexible routines emphasizes relationship-rich caregiving, which enhances emotional well-being and cognitive engagement. Residents experience fewer hospitalizations, lower rates of psychotic medication use, cultural change movement. Residents' traditional institutional care into resident directed living environments incorporates personalized music therapy, reminiscent work, and meaningful daily choices to improve engagement, reduces behavioral symptoms, often treated with sedatives, especially in dementia care. Behavioral health integration models uses non pharmacological approaches like CBT informed interventions. Mindfulness and trauma informed care to address aggression or mood disorders. Staff trained to distinguish between medical symptoms and psychological needs, reducing overuse of antipsychotics. Memory friendly housing and smart environments leverages ambient assisted living systems, predictive behavioral algorithms, and therapeutic design, lower stimulation spaces, clear wayfinding. Residents feel safer and more in control, decreasing behaviors often labeled disruptive. Would you like to explore these models? Would you like to explore how these models could be incorporated into adult daycare programs or smart housing? You're already analyzing design impacts. Maybe we could dive into ways these innovations scale in frailty aware care plans. Absolutely. These models aren't just changing the atmosphere of elder care, they're actively reshaping mental health outcomes for residents. Here's how they deliver uh, psychologically or psychological and emotional value far beyond what sedative can offer. Improved emotional regulation, personalized attention, and structured daily routines help reduce anxiety, aggression, and depressive symptoms. Residents feel safer and more in control, which particularly impactful for those with cognitive decline. Enhanced cognitive enhanced enhanced cognitive engagement. Activities like reminiscent therapy, storytelling, and music help maintain or even improve cognitive function. Mental stimulation can slow neurodegeneration, especially when environments designed to reduce overstimulation and confusion, strengthen sense of identity and dignity. Models like Eden and Greenhouse foster autonomy, agency, and individuality, all of which buffer against feelings of hopelessness, helplessness. Residents are encouraged to make choices in their daily life, preserving their sense of self. Reduction in behavioral symptoms, dementia related behaviors, wandering, aggression, repetitive speech, often lessen with non pharmacological interventions. By meeting psychological needs through human connection and tailored environments, there's less need for chemical interventions. Lower incidence of depression and loneliness. Relationship rich environments counteract social isolation, one of the strongest predictors of poor mental health. Regular interaction with trained staff, peers, and visitors provides meaningful emotional support, better sleep, and mood stabilization. Avoidance of sedatives leads to more natural circadian rhythms, improving sleep quality and daytime alertness. Smart environments can regulate lighting and noise levels to support mental and physical rest. The shift from symptom management to personhood support is profound, and you're already steeped in evaluating these design and the therapeutic strategies. Would you like to? Give me 1 second, guys. Be right with you. Would you like to compare how adult day programs or home-based models integrate these benefits, or maybe dive into the training protocols that empower caregivers to work effectively without leaning on sedation? To translate the mental health benefits of alternative care models into measurable outcomes, we need a blend of clinical indicators, quantitative assessments, and observational tools. Given your expertise, you'll probably appreciate a framework that ties behavioral, cognitive, and emotional matrix back to environmental and therapeutic interventions. Here's how typically here's how it's typically done. Cognitive health, meaning mental state examination, or MOCA, Montreal cognitive tests, assessments. Give me 1 second, guys. For baseline and progressive cognitive function, tracking outcomes of engagement with memory aids, structured activities, or therapeutic design in memory friendly housing, mood and emotional well being, geriatric depression scale, Cornell scale of depression in dementia, used in uh, used to engage residents' mood changes linked to pharmacologic non-pharmacologic therapies like dance, CBT, reminiscent work, or ambient assisted living features, e.g., soothing lighting or music. Let's see, quality of life and autonomy. QOL and AD, quality of life in Alzheimer's disease or adult social care. Give me 1 second. Outcomes kit. Outcomes toolkit. ASCOT scores to evaluate lived experience. Residents' ability to make daily choices, participate in meaningful routines, and maintain social relationships. Behavioral symptoms tracking. Use of tools like the neuropsychiatric inventory or NPI or Cohen Mansfield aggression inventory to track reductions in behavior, often misinterpreted as disruptive, such as wandering or vocalizations. Helps demonstrate impact of person-centered approaches versus pharmacological restraint. Sleep and activity monitoring. Wearable tech or sensor data in smart housing to track sleep patterns, mobility, and engagement levels. Data tied to environmental adaptations such as light therapy or noise control systems. Staff reported outcomes. Surveys like perceptions of caregiving, environmental scale, or structured interviews on staff satisfaction, emotional burnout, and ability to engage without relying on medication. These speak to both therapeutic climate and institutional integrity. Would you like to compare how these metrics align with adult day programs or intergenerational housing models, or dive into how predictive analysis and smart tech can generate early insights into declining mental health before symptoms become acute. An alternative care model that seek to replace sedative heavy approaches with person-centered interventions, evidence-based practices are key to ensuring both ethical care and measurable outcomes. Your grounding in frailty-aware environments and interdisciplinary methodology makes you specially equipped to appreciate how these practices are integrated across settings. Here's a created overview. Non-pharmacological behaviorals interventions. Personalized music therapy shown to reduce aggression and improve mood in dementia patients, supported by uh, meta-analysis, Cochrane reviews, reminiscent therapy, storytell strengthens memory and a sense of dignity, commonly used in memory-friendly designs. Missouri-based activities for dementia encourages cognitive and social stimulation through structured, familiar routines. Therapeutic environment design. Low stimulation architecture features like soft lighting, acoustic dampening, and uncluttered spaces, decrease stress and disorientation. Predictive behavioral algorithms used in smart housing to anticipate aggression and guide interventions before symptoms escalate. Wayfinding cues, memory triggers, virtual and sensory prompts that support navigation and cognitive recall in frailty aware housing. Relationship based care models, consistent staffing, alignments, assignments in greenhouse and Eden alternative models. Caregivers build trust over time, reducing behavior symptoms. Integrational engagement. Programs that include youth or volunteers have documented benefits for mood, motivation, and social connectivity. Therapeutic approaches, CBT informed practices, adapted for geriatric and cognitively impaired populations to address anxiety, depression, and aggression. Dance movement therapy enhances physical coordination and emotional regulation, particularly effective in early stage neurodegeneration. Mindfulness and breathing based programs improve emotional regulation. And reduce reliance on sedatives, especially in trauma informed care. Monitoring and evaluation tools. Use of QOL matrix, neuropsychiatric inventories, and wearable tech data enables practitioners to refine interventions in real time. Shared decision making frameworks guide ethical implementation, encouraging alignment with individual practices, preferences. Would you like to co-create a sample care plan or environment design blueprint that blends some of these interventions? We could tailor it for day programs, smart housing setup, or even research concept. Okay, guys. So that is it for tonight. I will try and do a show sometime tomorrow or Monday. So until then, I will see everybody. Gator Wellness, have a good evening. Take care, folks.